Okay.
I will be presenting on pediatric corneal transplant, my experience. It's still not moving. I have no financial interest in this presentation or in instruments used in this study. Ever since the first corneal transplant was performed, there have been significant improvement in eye banking, in surgical techniques, and also the new surgical procedures like endothelial keratoplasty have been introduced. But still, penetrating keratoplasty remains to be the gold standard for most of the diseases in adults. And the results have been gratifying. In some of the studies, even 10 years success for penetrating keratoplasty has been reported for more than 90%. Uh, but the scenario for the pediatric corneal transplant is different because of the challenges which we face because of the small eye in the children and shallow AC, forward bulging, and high risk of iris prolapse and other complications during surgery, plus increased risk of graft rejection, and of course visual rehabilitation and child cooperation is very poor. And also the long-term outcome of pediatric corneal transplants are not very much that much described in the literature. So I will be describing our experience. This is a retrospective study, non-comparative intervention. This was approved by the local like institutional review board. We have like retrospectively taken out 213 eyes of 178 children who underwent penetrating keratoplasty, for 178 for penetrating keratoplasty and 35 for deep anterior lamellar keratoplasty. Those patients who had more than 6 months follow-up, they were included. For surgical steps, the surgery was under general anesthesia, and the donor trepanation and host trepanation was decided on the basis of like a child's corneal diameter, and most of the times if the diameter was like 8 or 8.56 millimeter graft was given. Higher endothelial cell count donor corneas were used for these children. We used all the intraoperative measures to decrease the intraoperative positive pressure, and we monitored the body temperature by keeping the temperature of the operating room for neonates. And in post-operative treatment, we did frequent topical steroids and also frequent EUA. These are some of the indications and congenital and acquired for penetrating keratoplasty. For verbal cases, more than 50% of the children, they could achieve more than 660 vision. And for non-verbal children, they were able to like do their activities, and some of the children, they did not improve because of undetected optic nerve problems. There were several success stories, but just to share this one, this patient came to us with bilateral sclerocornea, bilateral microcornea, microphthalmia, and she was 5.5 months old. We did one eye in 2017, and she improved. The other eye was done in 2018. Now she is 6 years old and is going to school. She had one episode of graft rejection which was successfully treated. This is another group of the patients which is technically more demanding, because these patients having infantile glaucoma, their cell loss is much more compared to the normal patients, and more so if we have to do the tube for these patients. Deep anterior lamellar keratoplasty is much safer for the children, so these are some of the indications, and the complications are also less, and we have better results for deep anterior lamellar keratoplasty. Wherever possible, we do deep anterior lamellar keratoplasty for children, and our results are almost similar to those reported in the literature. In the end, I would like to say that the PKP remains the gold standard for visual rehabilitation in most of the children and infants. And it's only that if you have a congenital hereditary endothelial dystrophy or a failed graft, you can go for endothelial keratoplasty. Pediatric keratoplasty is challenging, but it gives good results, and good survival can be achieved with monitored follow-up. DALK is safer and less invasive and has better graft survival than compared to the complications. Some of the centers, they advocate Boston K-Pro for children as a primary procedure. We do not believe that, and we do not advise that. Endothelial keratoplasty can be done for selective cases. Thank you very much for patient hearing. Thank you.
Thank you, sir. I want to, just a question. What percentage of pediatric keratoplasties you are doing penetrating keratoplasty versus the lamellar procedures?
It's the incidence of deep anterior lamellar keratoplasty is much less. Maybe like if we are doing 8 or 10, then we are doing one lamellar.
Keratoconus. How many had a keratoconus, and you preferred DALK only in keratoconus, or you did
Well, the problem with DALK in children is that sometimes they come in a very, very advanced stage and acute hydros, where the deep anti-lamellar keratoplasty is not possible. Another group of patients which I have done, they have Down syndrome along with the keratoconus. So they are also very advanced. So I do DALK for children, but most of these children, they are not fit for DALK. And also those patients who have like vernal conjunctivitis with keratoconus, there of course we should not do penetrating keratoplasty. There we should do DALK because of the more risk of graft rejection, complications, and those problems.
Thank you.
Thanks.